This is Rick Mattson from the University of Washington Shoulder and Elbow Service. Let's talk about how to do a ream and run. We'll start with the patient preparation and the surgical approach. First, a little background. The ream and run is an operation that combines a humeral hemiarthroplasty, as shown here, with a non-prosthetic glenoid arthroplasty. And by that we mean that the glenoid is shaped with a reamer to exactly the right contour, and it is stimulated to heal over with fibrocartilage, as is shown here by early motion. This operation is designed for patients who wish to avoid the limitations and the risk of complications associated with a glenoid component, such as glenoid component loosening, as is shown here. This is a durable arthroplasty. Here's an example of a gentleman who had this operation 12 years prior to these x-rays and this clinical photograph. You can see he had severe arthritis of his glenohumeral joint, and here are his x-rays 12 years later showing nice resurfacing with a fibrocartilaginous layer between the glenoid and the humeral head in both the AP and the axillary projections. He also has a stable stem that was impaction autografted, and this has enabled him to get back to high-level activities such as chopping wood, as shown here. Now, before proceeding with a ream and run operation, we need to get a good idea about what the Patho Anatomy is of the shoulder. So we use some standard films. This is a AP in the plane of the scapula, also known as a Grashy view, taken with the beam perpendicular to the plane of the scapula and the arm in 30 degrees of external rotation relative to that beam. The next view is what we call the axillary truth view, which is taken with the arm in abduction, and this enables us to see if there has been any posterior decentering of the humeral head in the glenoid. And finally, we take a AP view of the humerus to see if there's any anomalies in the orientation of the humerus or deformities from previous injuries or fractures. So here is again the truth view, and you can see it enables us to easily get a handle on the pathoanatomy, whether it's what some people call an A2 glenoid or any of the varieties of B glenoids, which are characterized by posterior decentering of the humeral head on the glenoid. We do this surgery in the relaxed beach chair position, allowing easy access to the arm and full range of motion of the shoulder for trialing. The incision is made along the line connecting the coracoid process and the mid aspect of the lateral humerus. This enables us to avoid the axilla. We split the deltopectoral interval, take the cephalic vein laterally, and split the clavipectoral fascia just lateral to the coracoid muscles, staying on the safe side and not on the suicide. We identify the subscapularis tendon with the anterior humeral circumflex vessels right below it. We identify the axillary nerve and protect it, and we tailor our surgical approach to the preoperative anatomy. We need to take down the subscapularis through a subscapularis peel, and we need to release that subscapularis from the capsule beneath, preserving the glenoid labrum on the glenoid. In shoulders that are circumferentially tight, we may need to do a 360-degree extralabral capsular release. When the shoulder is posteriorly unstable, as indicated by the truth view in this example, we may only release the anterior part of the capsule down to maybe 5 o'clock or 6 o'clock. If we need to release that posterior capsule, we can twist the retractor, which puts it under tension, enables us to cut it safely, all the time protecting our axillary nerve. We expose the humerus by putting a dera behind it. Sometimes there's a big posterior osteophyte, so we need to lever that into the joint using a dera retractor as a shoehorn. Thank you.